Hello and welcome everyone. Today's presentation is the management of acute-on-chronic liver failure. Now, acute-on-chronic liver failure was first defined by Jalan and Williams in 2002 as a condition characterized by systemic inflammation and the failure of one or more organs, excluding the liver, in a patient who has acutely decompensated from cirrhosis. Now, the refinement in the concept was done in 2006, where they, through systematic review, analyzed the prognostic survival indicators in cirrhotic patients. So, a global research consortium was done, and which included all the major players from Asia, Europe, North America, and China, and developed definition for the criteria of ACLF, acknowledging extrahepatic organ failure as a key differentiator from decompensated liver failure. ACLF shares similarity with acute liver failure, with almost 50% of ACLF possibly experiencing recompensation. Those who don't achieve the recompensation may need a liver transplant similar to acute liver failure. The PREDICT trial. Now, pre-ACLF, as patients with cirrhosis having an unstable clinical course requiring hospitalization due to decompensation, indicates significant inflammation or sepsis with liver or kidney dysfunction. The current clinical practice gaps is that we are unable to recognize this pre-ACLF state, leading to delays in identifying patient at risk of ACLF and their admission to specialized units like an ICU. Now, typical ACLF triggers include alcohol consumption and infection, with the latter being a significant cause of acute decompensation. Identifying inciting events is crucial, especially since many infections do not typically present with the features of sepsis. Infections, often hospital-acquired with resistant spectra, play a critical role in the ACLF development. Timely antibiotic administration is crucial to prevent ACLF progression, emphasizing that treatment delays worsen patient outcomes. So, what is the definition of ACLF? There are various societies which have given various definitions. This table basically summarizes all these. According to the ESSL, the definition is acute worsening of a pre-existing liver disease, often triggered by an event leading to decreased 4-week mortality due to organ failure. While the Asia Pacific organization says acute deterioration in the liver leading to jaundice and hemostatic disorders within 4 weeks, causing ascites, encephalopathy in a known or unknown chronic liver disease with high 4 weeks mortality. While the North American Association says chronic liver disease with or without cirrhosis causing mortality within 3 months if left untreated. So as you can see over here, there is a lot of variation in the definitions that are used. Now, if you look at the liver criteria for ESL, it is bilirubin more than 12, for Asia Pacific more than 5, and for the North America, it is not specified. The extrahepatic failure is defined based on the renal, vasopressor, and the respiratory component. The type of insults are defined. That type frame is usually 4 weeks, and somewhere it is not specified. The disease severity in the EASL is by Cliff Sofa, by APSL, and the North American has no specific scoring. So as you can see, 3 big societies, no consensus and various definitions. So how do we define the systemic failure and mortality? So ACLF with no organ failure or single non-kidney organ failure with creatinine less than 1.5 is called no ACLF. Grade 1 is single renal failure or single non-kidney organ failure with creatinine 1.5 to 1.9 or HE grade 1 or 2. ACLF grade 2 is with 2 organ failures. Grade 3 is 3 or more organ failures. Now, this organ failure is correlated with the mortality. So as the grade increases, the mortality increases. At day 28, the mortality increases from 10% in no ACLF to grade 3 in 87%. In 180 days, it is 38% with no ACLF, which increases to 96% with grade 3. Now, what is the basic pathophysiology? What is cirrhosis-associated immune dysfunction? Now, following a precipitating event, cirrhotic patients exhibit a systemic inflammatory response characterized by elevated cytokines and the release of DAMPs, which activate the toll-like receptors, leading to a pathophysiological response distinct from that seen from acute decompensation in cirrhosis. So, the baseline is a systemic inflammatory response, which is not seen in acute decompensation of cirrhosis. The excessive systemic inflammatory response can cause significant circulatory instability, impaired oxygen delivery, worsening the tissue perfusion, and potentially leading to multi-organ failure. Both bacterial infections and alcohol consumption can initiate ACLF by activating the immune system through PAMPs, stimulating pro-inflammatory cytokine production, leading to hepatocellular injury and further inflammation. Cellular injury from hepatocyte results in DAMP release, exacerbating the inflammatory response. In the parallel, the PAMP from the bacterial infections amplify this response, leading to a very vicious cycle where the inflammation just keeps on happening, resulting in severe organ dysfunctions. Now, alcohol consumption compromises the immune response and promotes bacterial translocation from the intestine, escalating the inflammation and disrupting the normal immune functions. Immunosuppressive therapies often used in alcohol hepatitis can exacerbate immune dysfunction, increasing infection susceptibility. Cirrhosis leads to alteration in intestinal microbiota, impairing intestinal barrier defenses. These changes correlate with the severity of the liver disease, further complicating the disease's progression. The progression of the cirrhosis to ACLF involves multiple factors: the immune dysregulation, the pathogen progression like endothelial dysfunction, pro-inflammatory cytokines. These factors contribute to the organ failure and the development of the ACLF. So this schematic diagram summarizes this. You have a cirrhosis where you have portal hypertension and a dysfunctional immune system. With the trigger of infection and alcohol, this portal hypertension results in a systemic inflammation which causes pro-inflammatory cytokines, DAMPs, TLR activation and endothelial dysfunction, which will affect the liver function, which in turn results in more liver dysfunction. This can also lead to circulatory dysfunction, resulting in multi-organ failure. So the trigger results in a systemic inflammation which affects the liver function, resulting in circulatory dysfunction and multi-organ failure. So admission to the ICU and the cardiovascular management. There is an observed increase in ICU admissions from ACLF patients, with research indicating improved survival rates. However, ICU mortality remains high in certain subgroups. Prognosis varies with the reason for ICU admission, with GI hemorrhage patients faring much better than those with septic shock. Early admission to the ICU is associated with better outcomes, underscoring the importance of timely ICU referral for cirrhotic patients. Specific scoring systems like CLIF-SOFA and CLIF-C offer better prognostic value for ACLF patient compared to the general ICU tools or liver-specific scorings. Now, cardiovascular care essential, that is, cirrhotic patients often develop vasoplasia and systemic inflammation, leading to hypertension and increased cardiac output. The main goal is to ensure the tissue perfusion, aiming for a MAP higher than 70 or higher targets may have not shown much of additional benefits. Now the next is fluid management. Assess the fluid responsiveness. Crystalloids are preferred over starch-based solutions. 0.9% saline can be given with risk of AKI. So you can give either saline or balanced salt solution. Albumin may be considered for hemodynamic stability after crystalloids, although its overall survival benefit is debated, except in the case of spontaneous bacterial peritonitis. But then it does have a reserve role if you have already given a lot of crystalloids and you still find that the patient needs more fluid. Norepinephrine is the preferred vasopressor as usual, and the use of vasopressin as an adjunct can reduce catecholamine requirement and increase the blood pressure. But again, its impact on survival is unclear. Non-selective beta blockers can be used for managing the portal hypertension and have shown improved survival rates, possibly due to reduced bacterial translocation. While the cardiac protection in the setting is debated, current evidence does not strongly recommend discontinuing the non-selective beta blockers prior to the development of sepsis. AKI, what interventions we need to do and the care that needs to be provided. Prevalence and prognosis. AKI impacts approximately half of the hospital admitted patients with CLD, signaling decreased survival rates. HRS often accompanies ACLF. It is commonly categorized into two types. Type 1, which is acute and poor prognosis. Type 2, which is chronic with moderate renal dysfunction. The International Club of Ascites updated the HRS1 to HRS AKI, reflecting AKI criteria, noting that high serum creatinine levels at treatment start are linked with lower reversible changes. In ACLF with at risk of AKI, maintaining the adequate renal blood flow with fluid, if needed, inotropes to keep the MAP between 65 to 70 is very crucial. Vasopressors are recommended in volume overloaded scenario. Terlipressin infusion is favored over bolus for its better tolerability, and early AKI treatment increases kidney likelihood survivals. Norepinephrine versus vasopressin efficacy in reversing HRS and reducing 30-day mortality is similar, suggesting comprehensive treatment strategy are vital for management. Recent studies, including the Akiki Ideal ICU Start AKI, suggest that early renal replacement therapy does not improve survival, highlighting risk associated with the early initiation of renal replacement therapy. However, specific cases as the Alien study showed improved outcome with early RRT in surgical patients with post-cardiac surgery patients. Now, Akiki 2 study explored waiting for RRT, finding no significant difference in outcome between late and even later RRT, challenging the optimal time to start RRT. Patients invaluably requiring dialysis do not benefit from delayed initiation due to complication risks. An individualized approach considering the fluid overload and other dialysis indicator is essential. Despite ACLF patients with exhibiting hypercoagulability, anticoagulation is necessary for RRT to prevent platelet clotting. Regional citrate anticoagulation has been shown to be safe and effective for RRT in cirrhotic patients. Addressing the concern of citrate toxicity is also very crucial. Now, infection in patients with ACLF. About 46% of the patients with worsening cirrhosis have bacterial infection, that is SBP, UTI, pneumonia, bloodstream infection, or soft and skin infections. Now, the immediate administration of antibacterial agents upon presuming a bacterial infection is significant to improve survival. Delays in therapy or use of inappropriate antibiotic increases the mortality risk. The use of certain antibiotics can lead to shift towards more gram-positive infection and a rise of enterococci infection, highlighting the need for proper antibiotic stewardship. An increased incidence of MDRO in ACLF patients emphasizes the importance of controlling the spread of multi-drug resistant infections, especially in nosocomial setting among ICU patients. Empirical therapy with broad spectrum MDR shows superiority in managing nosocomial infections and severe sepsis, underscoring the need for accurate and timely antibiotic selection. Beta blockers used for managing portal hypertension might also reduce their bacterial translocation, contributing to the improvement in ACLF patients. Next is fungal infections. Patients with ACLF in ICU have high risk of fungal infections also, particularly aspergillosis and candidemia. Antifungal treatment should be considered in patients who are in the ICU. Tailoring antibiotic choice and treatment duration to the specific causative organism and sensitivity alongside efforts to minimize the antimicrobial resistance to stewardship program is essential. Biomarkers like PCT and CRP can aid in early detection of sepsis, though their use is limited by sensitivity and specificity concerns. No single biomarker currently is recommended for prioritizing sepsis management. Now, how does brain respond in this particular case? Association with cirrhosis. Hepatic encephalopathy is commonly linked to cirrhosis primarily due to the reduced ammonia metabolism, leading to symptoms ranging from confusion, decreased mental status to seizure and coma. Now, in ACLF, hepatic encephalopathy significantly increases the mortality risk, with cerebral edema occurring in 4% of the cases, indicating worse outcomes. The development of HE involves multiple factors, including elevated serum ammonia, hyponatremia, neuronal damage, disruption of the blood-brain barrier, and abnormalities in the neurotransmitter pathways. These factors contribute to the impaired mental status, generalized inflammation in ACLF exacerbating these effects. Management is addressing factors like infection, constipation, dehydration, and electrolyte balance. Medications affecting mental status should be discontinued. Treatment for hyperammonemia should be done, like lactulose, non-absorbable antibiotics like rifaximin, and the efficacy in ACLF is quite uncertain in these particular cases. Now, the HELP study indicated that the polyethylene glycol, that is PEG, may be more effective than lactulose, showing significant improvement in HE within 24 hours. RCT of the LOLA showed faster HE recovery and significant lower mortality compared to control groups, highlighting the potential of combining LOLA with lactulose and rifaximin. Now, previously, protein intake limitation was considered a management option for hyperammonemia, but it has been found to be potentially worsening the patient's nutritional status. So, protein intake is never limited. Manage the effect of that, that is hyperammonemia, rather than restricting the protein intake. Innovative treatment methods, that is novel approaches like oral spherical carbon absorbent ST120, which reduces the level of uremic toxins, are under investigation for potential to lower the ammonia levels. The Cochrane database reviewed 5 medications for ammonia control, finding that sodium benzoate, glycerol polyacetate, and ST120 were effective in reducing the blood ammonia levels. However, this did not significantly improve the over-absorbable disaccharides in lowering the serum ammonia. Now, while these devices have been shown to reduce the ammonia levels, that is the liver assist devices, studies have not demonstrated improvement in mortality in cirrhotic patients treated with liver assist device. So looking more closer into the impact of the liver assist devices. The first is the bioartificial liver assist device, the ELAD. The extracorporeal liver assist device, ELAD, uses hepatocytes derived from hepatoblastoma cell line to perform liver functions externally. A phase 3 trial with 203 severe alcoholic hepatitis patients showed no significant difference in survival who were treated with ELAD combined with standard care and those receiving standard of care alone. Now, subgroup analysis indicated a potential survival benefit in younger patients with lower MELD scores, but this was not statistically significant. Next comes the non-biological devices like the Prometheus system. It utilizes fractionated plasma separation and absorption to remove both albumin-bound and water-soluble toxins. The Helios study involved 145 ACLF patients and showed reduced bilirubin levels with the Prometheus system, but no survival benefits were seen. Next is the Mars system, that is molecular absorbent recirculation system. It features an external blood circuit with an albumin-coated membrane alongside dialysis circuit for removing the albumin-bound toxins. The RELIEF trial did not find difference in transplant-free survival in 28 or day 19 ACLF patient treated with Mars compared to standard of care. Re-evaluation of Mars treatment in ACLF used updated ACLF criteria showed significant reduction in bilirubin levels, improvement in hepatic encephalopathy, but no impact on survival. The treatment is, if the patient is not recompensating, is liver transplant. But then we must be aware of what are the futility criteria of the liver transplantation. So there are various definitions to define futility of liver transplant. Different researchers have proposed various definitions, including considering post liver transplant mortality exceeding waiting list mortality, specific risk incorporating like MELD score, comorbidity and other factors, focusing on short-term liver transplant mortality rates. The absence of an universally acceptable definition complicates the decision making for liver transplant, highlighting the need for more objective criteria to guide the decision or when to refuse it. A survey among transplant centers in the US revealed a general inclination to proceed with transplant for candidates with higher MELD scores, despite needing significant ICU support. Now, criteria for refusing liver transplant include high dose of vasopressors, severe oxygenation requirements, and certain septic conditions. Now, severe frailty and specific thresholds for organ failure have been proposed as factor to contribute when postponing or denying liver transplant. The development and implementation of delisting criteria could help make the liver transplant allocation process more objective, reducing pressure on the clinicians and allowing more systemic evaluation for potential liver transplant outcomes. Although liver assist devices have shown benefit in managing conditions like hepatic renal syndrome and HE, the role as a bridge to liver transplant in selected critically ill patient is recognized. Yet, a clear advantage based on survival is not yet proven. So this flowchart basically summarizes the management of ACLF in ICU. First, check the patient's presentation. Evaluate the signs of chronic liver disease. Look at the history, physical examination. Look for the acute decompensation, whether it is jaundice, ascites, varicose bleed, or encephalopathy. Next, in your initial assessment, check at the lab values. Look for CBC, liver panel, coagulation, renal function, electrolytes. In imaging, do a Doppler of the liver. In special tests, you can do a paracentesis or endoscopy. Severity scoring can be done with MELD or SOFA, but for ACLF, the Cliff SOFA is much more better. Now, identification of precipitating factor is very, very important. Try to search for a precipitating factor. Usually it is an infection. Then search for the site of infection. Evaluate the alcohol and drug toxicity. Check for any GI bleed. Assess for other potential triggers like new medication, any metabolic disturbances. Now, what are the management goals of ACLF? First and foremost, cardiovascular stability. For that, give fluids and vasopressors, give a proper nutritional support, do not restrict the protein, specific interventions like ammonia reduction, antibiotics for the infections, vasopressors, endoscopic therapies, liver support devices can be used to prolong the management. Then evaluation for the liver transplant. You need an early referral and also evaluation for severity scoring for eligibility for transplant. Now, escalation or withdrawal care, if the patient fits within our criteria, we will escalate our therapy and go for transplant. If the patient is not fitting, we can think of palliative care. Long-term management, regularly monitor these patients for the recompensation and also try to manage their chronic liver disease. Thank you for your patience.